Okay, so I'm going to give you a brief overview on global health. It's a short presentation, basically just showing you some numbers, okay? Showing you some data on where we are in terms of health over the world and what's left to do. What's left to do as bioengineers? Well, quite a lot, but you know, well, what numbers we have and where you can find those numbers should you want to further understand where we are and look at some of the very interesting data that we have available. So this is just an overview, and I'm going to start with the Sustainable Development Goals because this is where we're starting the school from. So as I mentioned, you're going to learn about these in the next lecture, but there are 17 SDGs, and they relate to different aspects that the UN outlined for the world to look at objectives for 2030. Okay, so different objectives in different areas. So a question that I'm going to ask you, just have a quick look at them. You will look at them lots of times, but which of these pertain to health specifically? Or how many pertain specifically to health? Anybody? Okay, I'll ask you to put your hand. Does number 1 pertain to health? I mean, is it related to health? Goal 1? Yes, no, yes. How about number 2? Yes. How about number 3? Obviously, it's got health in it, right? How about number 4? No? Yes? Maybe. If you're healthy, then you can go to school. If you're not healthy, you can't go to school. So in a way, yeah. Number 5? Maybe. How about number 6? Okay. Number 7, 8, 9, maybe less so. But what I wanted to underline is that the first 6, at least I think, pertain to health in some way. Okay, so even number 5, gender equality, it's about contraception as well. It's about women having access to, you know, good birthing facilities, but also access to work because somebody's looking after their children and their children are healthy. So really many of these goals, so just under half of them, are related to health. Health is really important, okay? Some people say health is wealth, and I think that's true, because if you're healthy, then you can work. If you're not, then you can't, okay? So the baseline goal that these all have in common is good health, and good health for everyone, all right? So that's a key term that we're going to be using, health equity. Health equity means that everybody has access to quality healthcare, whether they are rich, whether they are poor, whether they are sick, whether they are well. They have a baseline of accessibility to healthcare. Okay, and this is really important for the UN. It's really important for all of us, and it's one of the goals of Ubora. So through collaborative biomedical engineering design, we aim for health equity through the development of biomedical technology that is accessible and sustainable, affordable. Okay, so access to healthcare is very, very important. It's, you know, a major goal for the UN. And what does health equity actually mean in real terms? It means that everybody has the same healthcare, and that the healthcare system provides for everybody, whatever their economic means are, okay? And this really means that governments have to work to provide healthcare coverage for everybody, okay? It requires political will, okay, at a government level. It requires good infrastructure. So it requires hospitals, it requires good equipment, and also it requires that this equipment is easily repairable and it's always up to the mark and it keeps up with research and innovation. So it's important to have access. It's important to have, like protection against infectious diseases. It's important to have vaccines, access to medicines, etc. But that comes through an adequate healthcare system, okay? And there are different models of this all over the world. Quite often, all the machines are in place. There's huge hospitals in the big cities, but in the rural areas, people don't have access to that, to those hospitals, because they live far away. So, you might have the infrastructure, but people may not be able to access that infrastructure. So it doesn't always go hand in hand, having accessible healthcare and having universal access to that healthcare, okay? So it's there, but you can't get to it. Or even worse, there's some countries, for example, in which they have huge centralized hospitals with really good equipment, but people with chronic diseases do not have access to daily care, daily checkups. For example, people with diabetes may not have a chiropodist look at them regularly, or they may not have blood checks or pressure checks regularly because nobody follows them up. So it's quite difficult even for governments to decide, which end they need to concentrate on. Do they need to concentrate on improving access to vaccines, or do they need to concentrate on high-end equipment in hospitals that maybe very few people need? And that's always something that is, one has to decide which are the pros and the cons of dedicating money to one aspect or another. And there aren't really any perfect models. There are many countries have models for investment in rural community healthcare, whereas infrastructures at a large level are missing, so that secondary care is missing, and others vice versa, where you have all super duper machines, but at the end of the day, you can't have a nurse visit your house. It's a problem that many countries are facing at the moment, and especially the poorer countries, which aspect to concentrate on. We'll look at some metrics, what goes on in the world and what the consequences of different types of care are. There are many metrics that we use to understand what the state of health is in a different country or in a continent or all over the world. And I'm going to show you some of them. I would invite you to, probe further into different aspects according to what your project is about, according to what your interests are. So we're just going to look at some of these very important metrics of health in the world: life expectancy, aging, and child mortality. And I'll invite you to look at the others on your own. So, yeah, okay. Right. So when we want to find data on the state of the world health, we have the internet. Where do we go? Where do we look for good data, reliable data? Well, that's also something that is part of a learning process. Where do we go? You go on the internet and you type statistics on World Health or something like that. And what do you find? You find lots of websites. I can tell you that possibly the most useful, at least for me, is the World Health Organization database and our World in Data. So I would ask you to just click on that. So if you want to find data on life expectancy, which means data on how old the average age of death is in the world, this is a graph of life expectancy in Greenland, for example, from 1950 to 2019. And you can see, for example, how the life expectancy in Greenland has increased incredibly. If you go down, can you go down? Sorry. Okay, no, sorry, go up, back up again. This is the wrong one. Just click on life expectancy here. Okay, go down. Carry on, carry on. Okay, here is the chart, which shows you a color map of life expectancy all over the world. And if you click on Africa, for instance, you can see life expectancy in different countries. You know, you move your mouse over it and you can see, for example, that it's quite low in Sudan. It's fairly high up in the north. I think that's Libya. In Congo, it's 60.7. In Libya, it's 72.9. That's the highest in Africa. Can you go to Europe now? So click on Europe. And here, the colors map is completely different, right? It's dark blue because life expectancy is much, much higher. For example, Italy is one of the countries in Europe that has the highest life expectancy, 83.5 years. And if you go to the USA, can you go there? Or Americas, North America? The USA, for a developed country, has a very low life expectancy. So it's much lower, for example, than the average in Europe. Okay, so the numbers are different across the world. We haven't all got to the same level. And it's a really fun and interactive tool that Our World in Data has. It's a really cool website to look at data on human health or anything else. And that shows you that, you know, we have differences across the globe for life expectancy. Okay, that means different access to healthcare, especially in old age. Can we go back? Okay, so down. All right. Sorry, back there. Okay, here's another interesting one. HALE, healthy life expectancy. This is an indicator of how many years of your life you live healthy and how many of them you don't live in good health. If you go to the chart, can you click on that? Okay, so here you've got life expectancy from 1990 for, I'm not sure which country. So if you put change country, just click on change country up here on the top left. Okay, so let's go to Italy, for instance. Okay, so here you can see that from 1990 to 2016, life expectancy has increased, but the percentage of years that one lives with disability has more or less stayed the same. And that's consistent across the globe. So if you change country, just go to any country you want, just go to, I don't know, India. Okay, again, you see life expectancy has increased, but the years that one lives with disability as a percentage has remained the same. Okay, so this healthy life expectancy is something that we're struggling to improve. So we can improve the lifespan, but we can't improve the quality of life in those last few years of life. And so this is a problem that I think will become very important in the future. You know, it's a problem we need to address because we can't increase life expectancy and yet expect people to live an unbearable, sometimes, quality of life in the last sort of 6 to 8% of their lifetime. Can you go back? Okay, yeah, it's getting a bit of, okay, so this, as it says here, you know, life expectancy has increased, but the healthy life expectancy as a percentage has remained the same. And it's not kept pace with the increase in lifespan over the last 20, 30 years. And as I mentioned, this will be an important issue to face in the future, and something that I think as biomedical engineers, you know, it would be a really important challenge for us to look at and to face and to work together to improve. Another very important indicator of health in the world is child mortality. Okay, so this is the number of children who die before the age of 5. And there's also another parameter called infant mortality, which is the number of children who die before the age of 1. So I've got 2 charts here. So you can, if you click on the first one, this is child mortality over the world. And the number of child deaths has actually decreased a lot globally over the past 20 or 30 years, as you can see from this graph. So it was 12 million a year over the world, and now it's 6 million a year. Okay, but it's actually very, very different across different countries in the world. And one of the SDG goals is actually to decrease child mortality, get it to 2.5% across the globe, and we're nowhere near that. Okay, we're a long way from having a child mortality of 2.5%. If you can go down, you can see some graphs. Click on, let's see, child, yeah, there you go. Okay, so here you can see the data across the globe. So even though the numbers have gone down, they are still fairly high, especially in Africa and parts of Asia. Okay, so we're nowhere near the SDG goals. Europe is doing very, very well. Very few deaths of children under 5, but not so well in India, for instance, or in the Republic of Congo. The same with infant mortality. I won't go into that because I think you can understand and you can explore for yourself, you know, what the problems are and where we need to intervene to improve the state of the world health and improve health equity. So we won't go on to that one. Lasciamolo, torniamo alla presentazione. Sorry. Okay, so I'd invite you to explore these data yourselves. Okay, so we'll carry on. Oops. So you can see the percentages here, right? The aim of the SDG was to get to 2.5 by 2030, but we're still at 10-20% in a lot of countries, and so nowhere near SDG goals. Can we go back to the presentation? Okay, thank you. Oops. Okay, yeah. So the problem, as I mentioned to you, one of the problems for health equity, for attaining health equity across the globe, is the problem of selecting the right kind of healthcare model. There are different healthcare models, as I mentioned, across the globe. For instance, healthcare model in Cuba and in Thailand is based on improving, and very well, in fact, access to basic primary care, so access to community care, rural care, and that means access to preventative medicine, vaccinations, mosquito nets for malaria, etc. Okay, so whereas they may not have super duper hospitals in the big towns, they do have a large rural community, which is in a very good state of health at the moment. So if you look at their data, they really do have a healthy population, even in rural areas. In the EU, on the other hand, it's a little bit different. We have huge hospitals in the big towns, okay? But for instance, in my specific case, my father-in-law is old and he's diabetic. He very rarely gets recalled by his doctor to check his health condition, to check his blood sugar, his glycosylated hemoglobin levels. He rarely gets his eyes checked because we just don't have that kind of infrastructure in Italy at the moment for reaching out into the community and into the heart of the community where we have a lot of old people. So it's a completely different model from what they have in Cuba and Thailand. In Canada and Japan, on the other hand, they do have a very good local infrastructure for checking up on elderly patients and on women with young children. So that's another different model. And then in the USA, which is, like I showed you, a developed country, extremely rich, but with a very, with a comparatively low life expectancy compared with Japan and Europe. Okay, so they have very advanced technology, massive hospitals with really super equipment, but you have to pay for it. Okay, so they have a not very good healthcare model. And not only that, I think USA is not a good model. I'll tell you why, because they do not concentrate on preventative healthcare. Americans do not have a healthy lifestyle because they don't get told that they need to eat well. They don't get told that, to not be sick in old age and get chronic illnesses, you have to have a healthy lifestyle. So they have a model that obviously isn't working despite their GDP. Just finishing off with looking at engineering. Okay, so how can engineers help? Engineering has been used to improve societal welfare for many years. So, we've got different types of engineering communities that help creating infrastructure in developing countries. You've got engineering communities, for example, Engineers Without Borders, building bridges, helping build roads, railways, etc. Engineering for health is something that's a fairly new concept. Okay, it started as a concept at the beginning of this century. A few associations have come up dealing with biomedical engineering for improving healthcare, and I think Ubora was one of the first communities that was born just for engineering for health equity, and I think we've got a long way to go. And engineering for improving health and in a sustainable way and in an accessible way isn't really considered that important for many governments. Most biomedical engineers who come out of our universities don't really end up actually working directly for patient health. They work on, I don't know, nanotechnology or bioinformatics, looking at, like different sort of, I don't know, gene identification, but it doesn't really directly point to health equity, very, very directly. And in fact, I think this is underlined by data that was collected by the World Health Organization in 2017. They did a survey on the state of biomedical engineers a few years ago, and they sent out a questionnaire to all the countries in the world, and they asked them to give them numbers of biomedical engineers involved in healthcare. And across the globe, the numbers are really, really low and so diverse. So according to the country that looked at the questionnaire and the way that they perceived their biomedical engineers, they're everywhere. There are countries that had no data. There are countries that have 1,000 biomedical engineers, and that's impossible because, I look around me and, at our university, we have 120 biomedical engineers getting a degree every year. So it's impossible that even in Italy, we only have 8,000 biomedical engineers, or in the UK, 1,500. So officially, according to the governments, there aren't many biomedical engineers in the countries that were surveyed. So here is data for Europe. On the next page, I showed you already the data for Africa. If you click on this link here, if you can do that, the state of the title, can you click on that? You can see the, funciona? No, okay. This is where I got the data from, so the World Health Organization. If you go to visualizations, it's very interesting, this graph that comes out, okay? So here is all the data set. And in light blue, the countries that replied, in gray, the countries that didn't reply, and all of the data is kind of lumped into low numbers in around 1,000, 100, except for China. So they have 600,000, 661,000 biomedical engineers. So, you know, obviously the survey was not really accurate, but it does show that countries perceive biomedical engineers in very different ways. And so this is a data set that shows the confusion, okay, more than anything else. But it does also show that we have a long way to go as biomedical engineers towards directly improving health in the countries that we belong to and in the countries that we work with. Okay, so we can go back to the presentation. I'll finish that. I'll finish off. Possiamo tornare. Yeah. Okay. So we've looked at these parameters here. There's a lot more. I invite you to look at them yourselves. Okay, look at the databases according to the project that you decide to work on. Use this as a reference point, you know, for your projects. But also remember that this is a really important and useful database for developing your proposals, for developing your theses. I think it's really fascinating. I think it's really also very interesting to look at the economic burden of health, you know, how much countries pay, what their GDP, what percentage of their GDP goes towards healthcare, and also access to different types of equipment. If you look for data, you know, how many people have access to MRI equipment, how many MRIs per country in the world. It's very, very interesting to have a look at. So I'm leaving you with a kind of some kind of exercise to work on together, you know, comparing mortality across the world, trying to see how many MRI machines we have in different countries, and trying to understand if that in some way is correlated to access to good healthcare, correlated to life expectancy, and also compare the doctors per capita with biomedical engineers per capita, because that's a very interesting exercise. You know, we have a lot of doctors in many, many countries. It's absolutely not balanced with the number of biomedical engineers. And another very interesting question is, you know, to understand why life expectancy has increased so much since the beginning of the last couple of centuries. Reflect on the data, look at the data, try and understand it, because it's rich with information. And it'll help you, I think, with the work that you're going to be doing in the week. Okay, so I'll conclude with that. Just to point out that, you know, attaining health equity has to be done within the context of the community that we're looking at. There are definitely too few biomedical engineers that deal directly with healthcare, and that's something that you, I think, as the future of biomedical engineering, have to deal with, and have to try and face this challenge, try and really, you know, promote your skills to the medical community and to policymakers, and use good data sources. So start with the ones I showed you. I think those are the best, and I really don't think there are any other better sources of data apart from the World Health Organization, and then this Our World in Data, which actually collects that data and then presents it in a nicer and more fun graphical format. Okay, so with that, I'll finish, and